To discuss a little bit with you the management of cardiac shock, and it remains an important cause of shock. We may have thought that indeed with the advancement of the interventional cardiology, this could have disappeared over time, but it's not really true. We can see here these data, large database from US. You can see that over time, the total number of shock has still remained stable. And interestingly, the amount of patients presenting with shock has also remained stable over time. So this means that basically, despite our improvements, it doesn't change a lot. And even more recent data show rather an increase in the amount of shock identified in US compared to what occurred previously. And what is quite interesting, on the other hand, is to see that the mortality over time has decreased. You can see here from the mid-90s, it was way over the 70%, that it decreased around 50% in the early 2000s. So this means that we have improved the care of our patients in the point that indeed mortality has decreased, but nevertheless, this still remains a very important problem, both in incidence and in terms still of mortality. So in our management of patients with cardiac shock, we have several things to do at the same time. And the first one is, of course, identify the cause of the shock. Together with just after identifying is treating the cause of the shock, which is, of course, very relevant of nature. And at the same time, it's important to realize that it's really at the same time we need to have supportive therapy. This means that while we are doing our supportive interventions to try to understand what is exactly the cause of the cardiac shock, and while we are treating the cause with PCI or whatever, we also need to have adequate support of the heart and of the circulation to prevent ongoing damage to the tissues and the organs. So when we are looking at the etiologies, the list is quite long, and we can say, whoa, what? I have to go in all details here. Be careful. This is in the guidelines. You have almost all the causes, from the seldom one you will see once in your life to the things you will see twice a day. So really, at this stage, the most frequent ones are really, first, the myocardial ischemia, second, the arrhythmias, third, myocarditis and other stuff like this. And then we have some other causes we should not neglect. And of course, we still have to think at sometimes some other syndromes like Takotsubo syndrome and other stuff. But basically, we will base our management of Takotsubo on the management of the ischemic one until proven otherwise. So we really need to look at all these kind of factors once we do not find the most common one. But among the complication of the acute myocardial infarction, of course, the most frequent one is just, if I can say like this, the impairment in left ventricular function. But you can see that we should also look at many other aspects there, including mitral regurgitation or ventricular septal defect, which is also something that may occur in some of these patients. And the management, of course, will be totally different. In the rest of the talk, I will mostly focus on the management of the acute cardiac shock due to acute myocardial infarction due to an ischemic cause, because this is the most frequent one and for which we have the most important aspect in therapeutic interventions to manage. So we have also somewhat to think at the diastolic function, but diastolic dysfunction is mostly observed as a cause of respiratory failure, but only as a cofactor or contributor to cardiac shock. But it is seldom the sole cause. So don't rely only, if you just find normal systolic function and so on, you have to think that something else is causing cardiac shock if you are sure you are facing cardiac shock. And so just look cautiously at communications or regurgitations that you may find in these patients, much more than just a diastolic dysfunction. So identification and treatment of the cause is really the key. And for this, of course, we need to think at performing very rapidly the coronary angiography and, of course, to revascularize it when you have it. We have, of course, to look at valvular disease, as mentioned, and to also try to have some rhythm or rate control. So for revascularization, the data are there. These are the data from shock trial showing that indeed there is absolutely no doubt that early revascularization is the therapy to go. It seems obvious for us, but before that landmark trial, many cardiologists were reluctant to do any interventions during shock. And often they say, oh, okay, treat the patient, we will see after, we'll do the PCI when it will be stable. I don't want to see this patient dying on my table. And this really has changed the landmark. And for us, it's really great to have this because this changed a lot the way we manage this patient, because the real emergency now in these patients, stabilize, go to the cath lab, and revascularize. So supportive therapy is really one of the key factors, and for this we have to think at multiple different aspects. The first one is when we are discussing heart failure or cardiac shock, we also say, oh, these patients have pulmonary edema, let's give diuretics, it will improve quite a lot of this situation. Well, it's true and not true, because it's really useful when we have hypervolemic state, but not when we are in normal volemia. And remember that in the acute setting, fluid accumulation does not occur. Fluid accumulation only occurs as a result of the compensatory mechanism and hormonal changes that occur in chronic heart failure. So a patient with chronic heart failure is totally different from a patient with acute myocardial infarction. And remember that when we give diuretics on the flat part, this is quite beneficial, but not when we can give it here, because then we will have a decrease in stroke volume, and this is really a danger because in cardiac shock, the stroke volume is already decreased at baseline. So, and this is really recognized in the guidelines, because when we have the dry and cold shock, this is considered to be somewhat hypovolemic, and even fluid challenge should be considered in these patients. We do not have a lot of data showing that dynamic tests should be better than just performing a fluid challenge, but there is no reason to think that these should not work. So our approach of these patients is usually to use these dynamic tests. If the patient is intubated, pulse pressure variations are very useful. In other tests, we can consider the passive leg raising test and also the use of echo to really try to disclose which patient may benefit or not from fluids in these conditions. The second aspect to discuss is the impact of positive pressure. And indeed, the positive pressure will have different effects. On one side, it will decrease the preload. On the other side, also it decreases the afterload. And this is much more beneficial, of course, for our patients. Regarding preload, again, we have totally different effects depending on the position on the Starling relationship. And so this means that we have to be very cautious if our patient in the acute setting, because some of these may be on that stage. So sometimes we need to perform first the fluid optimization before putting some positive pressure to these patients. But otherwise, just consider positive pressure. This can be always useful in patients with cardiac shock. The second aspect is the aspect on the afterload. So remember that for generating a given pressure for the kidney or for the brain, the heart has to generate the same pressure in the heart if the pleural pressure is equal to 0. When we apply positive pressure for generating exactly the same pressure, the heart has to generate less pressure if we have some pressure in the pleura. And this is really one of the beneficial effects on the afterload by applying positive pressure. And remember that because these patients are in shock, and often these patients are acidotic, and they make a lot of efforts to try to normalize their pH, even though they fail, these patients often have negative pressure during inspiration. And so, of course, in these conditions, the afterload is even increased at baseline. And so that's why applying positive pressure in this condition is so useful to limit, indeed, the exercise in the respiratory muscle on one hand, but also to decrease the afterload of the heart in these failing hearts. So in practice, of course, we should not intubate all these patients, but we have to think at it in some conditions. So CPAP is often the best solution for most of the patients. However, we have to remember that if the patient is profoundly hypercapnic, sometimes non-invasive ventilation is with some pressure support can be considered. And also remember that if you are going to the cath lab and you need to have a patient with stable, and your patient is already agitated initially because he is in shock, you will not be able to perform the revascularization correctly. So sometimes intubating and ventilating the patient should also be considered, especially if you have to do this kind of intervention a little bit later on. So the other aspects are indeed the use of inotropic support and vasopressors. And of course, at some point we will discuss the mechanical support of the heart. So the real question, when you face this kind of patient with this kind of a heart, and you say, oh, should I give or not some inotropic stimulation? Well, the real answer is not really from the ejection fraction itself. It's much more from the output, because we are really supporting the heart for what it gives to the tissues. Otherwise, we would like to, let's say, rest the heart and do not stimulate the heart too much. However, if the tissues are not receiving enough blood, then we have to do it. So in these conditions, especially doing the measurement of the aortic VTI is something which is very important. And this helps us by measuring the cardiac output to indeed decide which patient should or not receive some inotropic stimulation. Also, the usefulness of SVO2 and lactate are very important, because these provide us some insight of the balance between oxygen delivery and oxygen consumption on one hand, and for the SVO2, and for the lactate, the balance between oxygen consumption and the real oxygen demand of the tissues. When we decide to use some agents, we have the choice between basically three types of agents. And the first one is, of course, the butamine, then we have milrinone and oxymone phosphodiesterase inhibitors, and then we have levosimendan. So for the beta-adrenergic stimulation, the stimulation is quite simple. We have receptor stimulation, we have cyclic AMP, we have then entry of calcium by several mechanisms into the cells that will generate the contraction. So this has been shown in many other trials that indeed the butamine improves the contractility, improves cardiac output, and increased stroke volume in these patients. But the question is, some patients do not respond, or some patients even are treated with beta blockers to begin with and do not respond to the butamine. So can we give some other agents? And so inhibition of phosphodiesterase can be something to consider. Indeed, when you have this kind of cycle, if for just one cycle, we have one contraction and then the muscle is stuck. So we need to have indeed the reverse here, which occurs under the influence of the phosphodiesterase. And of course, by inhibiting this phosphodiesterase, we can prolong the action of the beta stimulation. And so the advantage is that it can be additive to the butamine on one hand, or in patients who are treated with beta blockers, it can overcome the fact that beta receptor is blocked and to give some myocardial contractility improvement. The problem is that, of course, in the periphery, it's also vasodilatory by stimulating the beta receptor in periphery without any effect on the alpha receptor. So by this way, while the butamine usually preserves blood pressure, the phosphodiesterase inhibitors will decrease blood pressure, which is sometimes a limitation of these agents. But usually, as you can see here, there is some improvement in the cardiac index that is observed here, which is similar as the improvement observed with the butamine and a vasodilatory agent. Levosimendan is an alternative agent that indeed will not act on this pathway, but just will act directly to the, at the muscular level to sensitization to calcium, and will, by this way, promote contractility with minimal increase in oxygen consumption, because all the other pathways are very oxygen consumption demanding. And indeed, it seems to work in patients with cardiac heart failure. In patients with cardiac failure, it has been shown that the mortality is not really improved. And based on that trial, it was suggested that it should not be used better than the butamine and others. Remember that all these trials here were excluding patients who were with a cardiac shock specifically. So we do not have data on patients with cardiac shock regarding the outcome. So we are here in a black box. We just know that it is effective in treating the or improving the cardiac output in many of these patients, but we do not know exactly what will be the real benefit in terms of outcome with levosimendan in these conditions. The only data we have are more or less this kind of retrospective data showing that patients from registries treated with noradrenaline and levosimendan or noradrenaline and dobutamine have more or less the same outcome. But we have to be careful because maybe some difference in baseline condition may have favored the use of one drug versus the other one by the doctors. So this is very difficult to ensure that it is exactly equal or not. So basically, the societies recommend the use of dobutamine or milrinone or levosimendan in these patients. And it's very difficult to say which one is better than the other one. And so usually what we do is to use dobutamine as a first-line agent. Why? Because it is a short-acting one, and we can very, very rapidly titrate the dose of the agent. If not responding, we use milrinone, and if not responding, sometimes we consider levosimendan in these patients. Regarding vasopressors, well, vasopressors, norepinephrine is really the vasopressor of choice in these conditions. And of course, we have several that we can use in these conditions. However, if we look at the data, it's clear that norepinephrine compared to dopamine, norepinephrine is associated with a better outcome, significantly better than when we use dopamine. Regarding the side effect is really where we see the differences with much less arrhythmias compared to dopamine. Then, norepinephrine versus epinephrine. We do not have a lot of data, but still the data we have are not very supportive for epinephrine. This is one of these, a small trial, only 30 patients with cardiac shock, randomized to either epinephrine or norepinephrine. And what they observed is exactly the same mean arterial pressure, exactly the same cardiac output, but as you can see here, heart rate, which was quite higher with epinephrine compared to norepinephrine. Also lactate increase with epinephrine compared to norepinephrine, but also some other dangerous signs, which is the increase in the CO2 gap with epinephrine compared to norepinephrine, and a lower urine output with epinephrine compared to norepinephrine. The same investigator conducted some larger randomized trial with other centers, and what they observed is that at some point there was some, they have to stop their trial because indeed there were some differences there that were exactly the same as they were observing here. I'm not so sure it's better, but anyway. So they observed indeed that at some point they have to stop. So this trial is under submission in intensive care medicine, and I hope it will be published soon, because indeed it will help us to really guide our treatment and to probably forget about using epinephrine in cardiac shock. And indeed, if you look at registries, again, using epinephrine or adrenaline, if you prefer, is associated with a worse outcome compared to other vasopressors. There was a trend at some point to try to use some other agents like nitric oxide inhibitors, and as you can see, there was no benefit, no detrimental effect either, but no benefit with these agents. And so indeed, the guidelines suggest to use norepinephrine as a first-line agent in these patients, and in minority of patients, sometimes consider other agents. And then we have to come to mechanical support. Of course, intra-aortic balloon counterpulsation. This was the rule of our therapy 10 years ago, and then this trial from the German group was indeed showing that there is no beneficial effect for the systematic use of intra-aortic balloon counterpulsation. And several other trials in slightly different settings, perioperative shock and so on, confirmed exactly the same signal. So the balloon now should not be used unless you have some specific aspect that perhaps may benefit from the balloon. And in particular, if you have mitral regurgitation, this can be considered because indeed in this condition, the decrease in afterload may be considered. Then, of course, the ECMO is the last resource we have to use. And of course, when you have a patient like this one, with a markedly decreased aortic VTI, you should consider, indeed, ECMO in these conditions. And the data from different registries and so on suggest that, indeed, ECMO can be associated with some survival that is not observed usually in these patients that are close to die without ECMO. So the interest is that the mortality is really quite variable, it's somewhat evolved over time, but not so much, but it's really depending on the pathology. And usually, in an acute myocardial infarction, it's close to 45 to 50% survival rate. But the most important aspect still is that when you look at the long-term survival, it's usually quite good. So this means that your patient, if you are able to make this patient survive with the mechanical support as needed, this kind of patient will survive for a long period of time, usually thereafter. And you can see that indeed, worldwide, the use of ECMO, via ECMO, has increased quite markedly in these conditions, and it's probably something to be considered in many patients with failing to respond to classic medical therapy. But we should not be neglecting the fact that this patient may also encounter some very negative impact. And in particular, the neurologic impact is not to be neglected because indeed there is some risk of hemorrhage, there is some risk of embolus that indeed may generate some neurologic complications. So what say the guidelines or expert recommendations about the use of these kind of things? So first, of course, non-invasive mechanical ventilation, as we mentioned. Then the hemodynamic optimization, avoiding, of course, nephrotoxic drugs, but also invasive monitoring of the blood pressure and cardiac output, and entropic agents when needed, and vasopressors if required to sustain blood pressure and coronary perfusion pressure. And then, if the patient is unstable, consider the ECMO in some of these patients. So, the last point I want to cover in the next few seconds is how to identify the patient who may require ECMO, because this is really one of the most difficult aspects. And we do not have a lot of data. And one of these interesting data, even though not looking specifically at ECMO, was looking at what identify patients who are at risk of rapid death compared to the other one. And so they had hemodynamic measurements, invasive one, in they separate survivors and non-survivors. And it's interesting to realize that at baseline, at presentation, cardiac output is not really different. Heart rate is not really different. Slightly higher in non-survivors, cardiac output slightly lower in non-survivors. But the most striking aspect was really the coronary perfusion pressure, which was markedly lower in patients who will not survive compared to the other one. But interestingly also, the amount of vasopressors were not really different between survivors and non-survivors. So all we have initially is quite similar. Perfusion pressure is slightly lower, and then the evolution over time, of course, will differ markedly. Regarding the true echo data, we do not have. What we use ourselves in our institution is when we have patients who fail to respond to classical hemodynamic therapy and remain in the criteria that are usually considered to be non-weanable from ECMO. And these patients, we consider that if they cannot be weaned from ECMO, it's probably an indication also for ECMO. So in our side, when VTI remains below 10, despite entropic simulation, in these patients, we really consider to insert ECMO for the next few hours. With this, I thank you for your attention.